Hello, I'm Dr. Shelli Kessler. I'm a cognitive neuroscientist at the University of Texas at Austin. My research program focuses on using non-invasive brain MRI scans to predict brain health outcomes in patients with cancer. And this includes cognition as well as survival. And I'll be talking about both of those in this presentation. Approximately 6 out of 10 patients with cancer will experience cognitive decline as a result of cancer and/or its treatments. And this means that there are currently about 10.2 million patients at risk for cognitive impairment in the United States, which is twice the number of people with Alzheimer's disease. And these estimates are based on symptom assessments of cognition. If we use biological diagnosis of cognitive impairment, the estimate is even higher. On average, patients with cancer show cognitive function that is about 30% lower than expectation. To put this in another context, this corresponds to having a systolic blood pressure of 158, which is considered stage 2 hypertension and typically requires medical intervention. And using brain MRI, my group has shown that cognitive effects of cancer are analogous to 5 years or more of brain aging. Some patients show cognitive effects at diagnosis, and this may depend on the type of cancer. For example, cognitive changes are often an initial sign of glioma. But even non-brain cancers, such as breast and hematologic cancers, can be associated with cognitive effects at diagnosis. And cancer treatments, such as chemotherapy, radiation, immunotherapy, and so forth, are also associated with cognitive changes. And cognitive decline can occur during therapy or right after therapy, or can occur later on after therapy is ended. And among the patients who do demonstrate cognitive decline, a majority of them show permanent impairment that does not improve on its own. Cognitive decline reduces quality of life. It disrupts educational and occupational achievement. It reduces social role performance and can increase psychological distress. Patients who have cognitive impairment tend to have lower survival rates. And this is true for patients with non-brain cancers as well as those with brain cancer. In fact, the study that's shown here involved patients with non-brain cancer. One of the main problems in dealing with cognitive effects is that we don't know which patients will fall into that 60% group who have impairment. If we could predict a patient's risk, then this information would be really critical for treatment decision-making and patient counseling and preparation. We use standard of care non-invasive brain MRI scans to measure the brain's network, which is known as the connectome. And the connectome provides valuable insights regarding how the brain works, including how it balances the opposing demands of efficient communication with metabolic limitations, and how pathology is transmitted from one region to another. The connectome incorporates many important predictors of outcome, including age, sex, socioeconomic status, education, race, and genetic risk, among others. And these effects tend to be reflected throughout the brain. Our research has shown that the connectome also reflects the effects of cancer pathology, tumor genotype, and cancer treatments. And these effects tend to target very highly connected hub regions that are the most active metabolically in the brain. And pathology tends to begin in these hub areas and then spreads along brain pathways to other regions. What all of this means is that the connectome incorporates all of these really critical predictors of outcome. As I mentioned before, there are measurable changes in brain function in patients at diagnosis before any treatments have begun. And this is true of both brain and non-brain cancers. In this study, we showed that patients with breast cancer have subtle but widespread differences in brain function compared to non-cancer controls. And these regions are shown here in the different colors. And so we believe that these changes might make the brain more vulnerable to cognitive deficits later on, especially after neurotoxic treatments begin. We expected that the pre-treatment connectome would predict future cognitive outcome better than any patient or medical factors because, as I showed you, the connectome already incorporates most, if not all, of these factors, in addition to many other important predictors related to cognitive health. So we tested 3 different prediction models. One had only patient and medical predictors. One combined those patient and medical predictors with some selected connectome predictors that are commonly disrupted in patients with breast cancer. And a third model included the entire connectome. And we wanted to build models that could predict which patients would have future cognitive impairment 1 year after chemotherapy treatment was complete, or in other words, what is considered to be long-term permanent cognitive impairment. To create these models, we use machine learning, and this involves first training a computer algorithm to recognize the patterns of data that are associated with cognitive impairment. Then you show the algorithm some new data that it's never seen before and ask it whether the pattern of data indicate impairment or not, and you can then see how accurate the algorithm is performing and try to make adjustments to increase that accuracy. So the patient and medical model for predicting 1 year cognitive impairment was only 67% accurate, which isn't very useful in practice. It's slightly better than chance, but not great for predicting outcome in a clinical setting. The model that combined patient and medical predictors with the select cognitive predictors was 75% accurate, so much better when we add those connectome predictors. The model using the entire connectome without any patient and medical factors was 100% accurate at predicting who would have cognitive impairment 1 year later. And since our models use pre-treatment data, they could potentially be used to determine risk of cognitive decline before treatment begins and could therefore help with that treatment decision making. And we are currently validating and refining these models in a large multi-site study with the goal of making them reliable for implementation in the clinic. Because cognition is linked to survival, as I mentioned earlier, we then applied these same methods to build models for predicting overall survival in patients with glioma. And we again wanted to use pre-treatment data so that if successful, our models could be used to inform treatment decision making. So in addition to our whole brain connectome model, we again tested some comparison models. One model included only clinical data, which is known pre-treatment. So this includes age, sex, tumor location, hemisphere, and multifocality. Another model included radiomic predictors, which are predictors that are taken from the pre-treatment imaging of just the tumor itself. And we also included what we called a clinical plus model, which included all the clinical model predictors, as well as some predictors that are only known after treatment, after surgery, such as tumor grade, histology, and extent of resection. So this model was actually given a big advantage over our pre-treatment models, but we wanted to see how the connectome model would compare to it. Now, radiomics is frequently used to predict outcomes in glioma, but there are several disadvantages to this method. You have to manually separate the tumor from the rest of the brain, which is a very time-consuming process that can be prone to errors and difficult to replicate between raters. On the other hand, connectome construction is completely automated. Radiomics also requires a lot of different brain imaging scans, many of which are not standard of care, and some which involve contrast agents. And connectomes can be constructed from a single standard of care brain MRI scan, and they don't involve any invasive procedures. But most importantly, radiomics ignores the rest of the brain, which, as I've been saying, contains a lot of critical predictors. So, how did our models of glioma survival perform? Well, as expected, our whole brain connectome model was significantly better than all other models, predicting survival with 88% accuracy, and better even than that advantaged clinical model. We were also able to predict tumor genotype in terms of IDH status with 94% accuracy. A tumor genotype is highly predictive of glioma survival, but genotyping is not available for all patients. So these connectome prediction models could provide an alternate method for determining tumor genotype if other methods are not available. And we are currently working on a much larger study to, again, validate these models for clinical use. So my goal for this body of work is to develop a clinical tool that uses brain MRI to predict important outcomes for individual patients. And I have already developed and published open source software for measuring connectome properties from MRI. So this would be included in the back end of this tool, along with our machine learning algorithms once they're fully validated. And in closing, I'd just like to acknowledge my collaborators and funding sources, and especially my team here at the Brain Health Neuroscience Laboratory.